it's the top of the hour, so we'll go ahead and get started with the webinar this evening. Thank you so much for joining us. My name is Crist, and I'm the moderator for this Fellows webinar, Lower Extremity Deformity, How to Plan and Execute Proximal Femoral Osteotomy. For the Fellows webinar series, we really appreciate everyone being involved. We want you to be involved. We feel that the AO family is great for education, but also mentoring amongst our peers. And so we want to develop you as an educator to teach folks around you, as well as develop a network of peers and mentors. And the webinar series happens at 8 p.m. Eastern on Wednesdays, and it's a 4-year curriculum, 6 topics a year. The topics include pelvis and acetabulum, femur, pilon, lower extremity deformity, and then bone defects and non-unions. For this particular meeting, just remember when you ask questions, and we really want you to get your questions answered, use the Q&A function and do not use the chat function. We won't be responding to those in the chat, so really just use that Q&A function. Please don't use the raise hand function of Zoom. It just kind of complicates things. We won't answer your raised hand. We will answer your questions throughout, but if we feel that it would be a great one to give to ask the entire panel, we'll save that for the question and answer period later. You have a great group of faculty that are presenting topics this evening. We have Roger Wilbur, who comes from us from Cleveland, Ohio, Joel Williams, who's at Rush in Chicago, and then Keith Mayo, who is in Seattle. And they're experts in the field. These are our disclosures. None of them are specifically relevant to this talk. So what we're going to do tonight is we're going to start out with clinical and radiographic evaluation for femoral neck nonunions and that deformity. Dr. Williams is doing that, and then Keith Mayo will go over pre-operative planning. Roger Wilbur will go over how to perform the osteotomy, giving you tips and tricks and things to avoid. Joel will then go on to talk about complications and pitfalls. And then we'll have a question and answer period, and we'll have a case that we all go through together as a panel, and then we'll wrap up. And we'll probably more likely adjourn between 9 and 9:30. So this is the case for later. So I want you to think about this while the webinar is going on. So this is a 36-year-old firefighter who fell 20 feet while at work 9 months ago. He had his lateral compression type 1 injury fixed with a iliosacral screw. He had a right distal raised fracture that was fixed and a right femoral neck fracture. He then got referred to me because he continued to have groin and buttock pain and was noted to have this femoral neck nonunion. And it did change position as time went on. It was not reduced in that position. He was currently light duty at work and was using meloxicam and gabapentin. So the learning outcomes or objectives for this webinar are to appreciate the common deformity in femoral neck nonunions, recognize the goal of recreating the proximal femoral anatomy and providing a favorable environment for fracture healing, and then list the steps and importance of planning the procedure. And so we're going to just briefly go over indications for an intertrochanteric osteotomy to address a femoral neck nonunion. And so this is a great book that you can still get in a PDF format. It's an older book, as edited by Dr. Schatzker, but it had a lot of great surgeons that were involved in this textbook. And I thought it was very, basically had the same indications that most of us use now. And really to point out, this is Dr. Mueller did the chapter on this, but really what we're focusing on for this webinar are all non-unions of the femoral neck with a viable head. And sometimes that can be difficult to decide, but most of the time you can decide or choose or see that based on radiographic or advanced imaging. And the important thing is all femoral neck nonunions with a viable head, as long as repositioning it with the osteotomy will convert forces of shearing and displacement into forces of compression. These are the other indications that were in that chapter, but we're really focusing on the femoral neck nonunion. So with that, I'll turn it over to Joel and we'll go over clinical and radiographic evaluation.
All right. I think my Zoom window is still being shared. Brad, are the slides coming up okay?
Yes, we can see them.
Okay. All right. Thanks, Brett, for the introduction. I'm Joel Williams. I work in Chicago at Rush in a Cook County hospital. And for the next 10 minutes, Brett has asked me to go over these 4 objectives. It's pretty straightforward. History, physical examination, diagnostic imaging, and labs. And I think it's important to keep in mind that these cases are different. These patients are different than most trauma cases. They require some extra time and a thoughtful workup and plan in order to have success. Very first slide, I encourage you all to get your hands on this paper. Look through it if you already haven't right after the webinar. And it's also helpful to have right on your desk as you're planning one of these operations. It breaks it down very concisely in a step-by-step manner. So the first step with any of these patients, per usual, is a history. Obviously they have to have a history of a previous proximal femur fracture, probably femoral neck fracture. And I think it's important to ask the patients what their understanding of their weight-bearing restriction was afterwards. Maybe they were a polytrauma patient, and sort of in your mind have a mental graph about their sort of chronology of symptoms. I think this is probably the only image of a total hip in this entire webinar. And I think, unfortunately, at many hospitals, this is the default conversation or treatment for femoral neck nonunions. I'm optimistic and enthusiastic that all of you have logged in to learn about this operation. And I do think total hip is worthy occasionally of consideration if the patient had antecedent symptomatic OA or if their femoral head is non-viable. However, the vast majority of femoral neck nonunions are best treated with a valgus intertrochanteric osteotomy. The exam sort of breakdown is shown here. The first step, at least for me, is inspection. And this unfortunate resident was with me in clinic when I was putting this talk together. So he was kind enough to let me use him as a model for these exam photos. Oftentimes with hip or intra-articular pathology, patients avoid sitting in an upright position. They're often slouching or listing away from their affected side. When they're upright, they may not want to put all of their weight on their affected extremity and may hold their hip or knee in a flexed position or stand on their tiptoes. There are many ways to qualitatively assess limb length inequalities. My preferred method is to have the patient stand, hips extended, knees extended, facing away from me, and palpate the iliac crest. And if you detect a discrepancy, you can position the patient as shown here to figure out whether it's a femoral and or tibial asymmetry. And really, this is going to become much more relevant when we see the part of the planning exercise where we're talking about shaft medialization or lateralization. So spend some time looking at and thinking about what their native alignment is, which is going to become important once we're putting pen to paper and coming up with a plan. So oftentimes, so after the inspection, I move on to a gait examination, and patients will often shorten their stance phase to minimize pain. That's common amongst all or many lower extremity conditions. And there are varying degrees of gait dysfunction, which may be present in these patients and can often be due to abductor weakness and or a sort of subconscious effort to reduce forces on the hip joint. So this is an image showing what a true Trendelenburg gait is. The pelvis drops away from the affected side, as opposed to a compensated Trendelenburg gait or a Duchenne type of gait pattern where the torso is thrust over their affected side, which tends to happen sometimes with or in conjunction with the Trendelenburg gait, but usually afterwards. It's common in a proximal femur nonunion or femoral neck nonunion to have decreased internal rotation on the affected side. And that's commonly because one of the typical deformities is retroversion or retrotorsion. And I think it's important that you spend some time getting to know what their normal arc of motion is. There are some percentage of the population which has a drastically asymmetric arc of motion, but oftentimes it's pretty similar. So look at hip range of motion in a couple different positions. The images on the left show supine extended. Middle images show supine with the hip flexed at 90, and then the images on the right show prone. And it's uncommon, but I think it's important that you be sure the patient doesn't have a joint contracture. And if there is one present, I think you might consider capsulorrhaphy or arthrolysis in addition to an osteotomy. Just one slide on strength. I think it's important you do a thorough manual motor testing. And I think it's common, especially if somebody has a painful hip, to have some abductor weakness. But if somebody has a profound amount of weakness, a further neurologic examination, perhaps starting with an EMG, I think is warranted. This is a sort of quick and dirty way to load the hips and knee joints, ask the patient to squat way down close to the floor, and then do a duck walk if possible. I think it's pretty helpful just in general for lower extremity pathologies to see how mobile or not, or how flexible or not a patient is. The Stinchfield test is the patient's supine, knee extended, and then you apply force to the anterior femur. And it's non-specific, but if it is positive, it usually localizes pain to the hip joint or anterior portion of the hip. Fader test similarly is somewhat non-specific, but it does suggest some sort of anterior pathology. The imaging protocol is listed here. The x-rays that I commonly get are on the left. I do get a CT scan for pre-op planning in virtually all these cases. And I put MRI on this slide, but it's in gray, and that's sometimes indicated. We'll get into one slide where I think it's relevant. This first x-ray is a standing AP pelvis radiograph. It's important that you be sure the techs are positioning the patient so that you have a nicely rotated film. This is slightly rotated so that their left hip is probably a little bit anterior or a little bit closer to the emitter than the right hip, because you can see the symphysis is deviated a slight amount to the left. I'm sorry, rather to the right. If the hips and knees are fully extended on the standing film and you see an obliquity as shown here, you can measure the difference. In this case, it's 1.5 centimeters at the crest, or you can use the sourceals, the centers of the femoral heads, whatever your bony landmark of choice is. I think you should also include a standing AP of the hip and some sort of lateral. And then really, I find the most value in this image. And this is a patient position supine with max internal rotation. There's a reference ball up here so you can calibrate the image, which helps in the preoperative planning section. And I think it's important also to take a minute and be sure that everybody understands that the radiographic appearance of the neck shaft angle can vary significantly from the true CCD angle. And that's dependent on femoral torsion. And because that's an important planning variable, I think a supine AP pelvis radiograph with internal rotation typically should be taken to eliminate that distortion. So in other words, you want an x-ray to create your plan so that the neck and the shaft are parallel to each other, or in the same plane rather, and they're parallel to the x-ray cassette. So in most femurs, there's antitorsion, so that requires internal rotation of both femurs. In a femur, however, with minimal torsion, you may not need to really instantly rotate them maximally. The next step then is either on the AP pelvis or the AP hip radiograph, whichever your preference is. You can measure the Powell's angle, which will become one of the first steps in the subsequent talk. The next image is a standing mechanical axis view. It's again important to be sure the patella are pointed straight forward. To be critical in this x-ray, the patient's right lower extremity is rotated a little bit external, but I think the left side is forward facing. So this image can be used again to look at leg length inequalities and the mechanical axis. This patient's native mechanical axis is somewhat valgus, and you can see that on the left side, that's the unaffected side. And it's even more valgus, or the mechanical axis is further deviated, roughly 2 centimeters, just over 2 centimeters when we zoom in on our knees. And because the shortening mechanical axis deviation can be factored into correction, as we're going to hear about in the planning section, I think it's important to look at, spend some time looking at this in the clinic before you start making your plan. A CT scan can be used to confirm the diagnosis if necessary, but it's also useful for preoperative planning, seeing what bone stock's available, and assessing the femoral version or torsion. And just for clarity, version typically refers to the amount of twist that's in the femur above the lesser trochanter, and torsion refers to the entire amount of twist that's in the entire femur, typically below the lesser trochanter. So this is a composite or an overlay image created with an axial slice through the proximal femur laid on top of an axial slice through the distal femur. Many radiology departments can provide this for you and will oftentimes come up with some sort of torsional measurement. The orange lines are parallel to the distal femoral condyles, and the blue lines are right down the middle of the proximal segment. The orange lines are pretty straightforward and I think overall quite reproducible. There's a variety of different techniques to create the blue line. And that can be quite challenging, especially in a valgus neck, to come up with a reproducible line. So oftentimes, or actually all the time, I may glance at what the radiologist has provided, but I'll do my own measurements. And oftentimes that requires a couple of different slices of the proximal femur so that you're sure you understand the patient's torsion on their affected side and what their native torsion is on the other side. I think I've got a preoperative MRI in one situation. This was the patient. He presented about 3 weeks after this fracture for it's sort of a long-winded story, but in any case, he didn't show up at the hospital till 3 weeks after the event. So I was quite concerned about the viability of the head, and you can see some coronal images at the bottom that showed the weight-bearing dome of the femoral head looks largely unaffected, but the inferior portion is questionable. And last but not least, don't forget to address any correctable risk factors such as smoking or a metabolic abnormality or endocrinopathy. I think it's unlikely that correcting any of these things is going to make the fracture heal spontaneously, but obviously you want everything on your side so that the patient's going to have the best chance possible at having a good result. This can be done if you're comfortable, directed by the orthopedic team, or it can be done in conjunction with an endocrinologist or a fracture liaison service. And then, if clinically warranted, think about drawing infectious serologies. I don't think that's a standard part of my workup, at least, but if the patient had a history of prolonged drainage, et cetera, it might be worth consideration. So, in summary, I think we went over the highlights of how to evaluate these patients in the office before you start coming up with a plan and discussing their options. These are really fun cases and rewarding, but they can be quite challenging. That paper that I showed on the third slide, I think, is really, really helpful. And I encourage everybody to do a thorough workup and plan and just follow the basic principles to make them much more manageable. Thank you.
Thanks, Joel. We'll go ahead and move next on to Dr. Mayo, who's going to talk about preoperative planning. While he's getting his screen share, Joel, do you typically, I noticed that you had your extremity alignment series without blocks under. Do you ever put if you see them before you get the extremity alignment series, you notice there's a leg length difference, you try to block them out first to level their pelvis, just so you can get a better overall mechanical access evaluation?
Yeah, so I'll typically do both. The image as shown with without shoes or blocks. And then if the patient already has a shoe modification, I'll have them put it on and see what they look like, or if they don't, or maybe in addition, put some blocks underneath so I can figure out what their inequality is precisely as possible.
All right, thanks.
All right. So we're going to go quickly through a generic plan for an abduction or valgus proximal femoral osteotomy. And the goals are to apply a technique which is now 60+ years old, based on plain radiographs that Joel's already delineated. And it's a workflow that you can use no matter what the medium is. So even if you've never seen vellum tracing paper, it'll work on the digital platforms as well. And it's something I think that you probably should not try to short circuit. And the assumptions of these, that most, although certainly not all, long bone malunions, nonunions can be reduced to a single site of correction with 2 osteotomy components. Given that, you can have multiple different osteotomy configurations. And the ideal implant for this set of problems is one of the angled osteotomy plates, which for the most part are offset. They're double angled, and we'll look at why that is in a bit. But the problem is they are fixed lengths. They only have 4 side plate holes, and their blade is like standard blades, 14 millimeters in width. You need AP and lateral images. Joel's already discussed the fact that most of these are at least somewhat retroverted, and so the internal rotation AP view that you use, in my view, should be focused on the hip. So whenever I'm planning one of these, I have a dedicated AP of the hip. If it's a normal hip, I mean uninjured, then you have to compensate for total torsion. If not, then you based on your assessment of clinical rotation, you can decide whether you need to hold internal rotation. And you have these other image assessments, which Joel's already talked about. For those of you who think this came from the Smithsonian, it's actually my light box, and I still use it. You actually used to put x-rays on these things, but they're still useful for doing preoperative planning. Even more useful some evenings is a glass of wine, or sometimes more. This is my tribute to Jeff Mast, who is the father of modern preoperative planning. It helps if you're an artist, but it's not mandatory. So here's our patient, roughly 8 months after this femoral neck fracture. She's in varus. She's shortened, and you can tell from the original that she was probably never really reduced. So there's probably a rotational problem as well. And so where do we go? We have to go back to Friedrich Pauwels. And this is his original article from 1935, which is the femoral neck fracture mechanical problem. And this book, which is really still very elegant. He's not the father, but he certainly propagated the concepts of qualitative hip biomechanics, where the abductors are responsible for counteracting the body weight moment arm. And so that you have this situation that in the early days, they had many of these that were treated non-operatively with complete shear forces across. And the idea was then you could convert shear to compression, just like we saw in the original introduction slides. The early osteotomies were fixed with tension bands, and so this was a relatively insecure fixation, so the corrections were very large and quite distorting of local anatomy. So that brings up the question of how much distortion can you get away with and not induce a new set of biomechanical and or local impingement problems. And the original planning was to take your non-union angle. So if you go back to the original Powell's 1 was less than 30, Powell's 2 was between 30 and 50, and Powell's 3 was beyond 50 degrees relative to the transverse axis. And the goal was to convert your non-union to within 20 degrees of the transverse axis, which really is very distorting in many of these cases, and certainly not necessary based on results to date. And part of that reason is not necessary is because our mechanical fixation is so much better today with blade plates. CCD angles average 127 with a wide variability. Sometimes we'll see side-to-side variations of a few degrees, but remarkably not much difference in male, female, although there clearly are racial differences. There's a lot of discussion about shaft displacement with osteotomies. This does not pertain to cases where we're returning to normal. Okay, we're not going to, so if you're going to do an abduction, like the middle situation of a normal hip, then you may very well have a lateral mechanical axis deviation. But since we're returning to normal, this whole problem of where to put the shaft should be just completely ignored in this set of problems. We want a femur that looks like a femur at the end. So the sequence is a normal template along the lines we've already talked about, with, in this case, a CCD angle of 134. Then a non-union site, also compensated for rotation, and 110 degrees. So we have roughly a 25-degree side-to-side difference. And now we're going to overlay these two, and we're going to look at the frontal plane correction, which in this case is 25, and we're going to round up to 30, so we have a little bit more of a compressive effect. And then shortening, in this case a little over 1.5 centimeters, and then offset, which fortunately we don't have to deal with. It's probably the most difficult deformity in the truly shortened femoral neck, requiring other issues later on. So these are things we want to see on every overlay template so that we can correct them for the next steps. Now, the osteotomy options are multiple. You can do 2 oblique osteotomies, which compound the difficulty, or you can do 1 transverse component, which is the easiest, and then with another reference wire, you can do a closing wedge. This will give you 2 different components to work with. And again, we haven't configured the osteotomy yet, but we have 2 different components, and we can then overlay them, or we can bring them together and mate them in a variety of different ways. And there are really just 3 options. One is a pure opening, which is highly unstable, and you can probably only get away with this in kids. You can do a combined opening closing, which is usually what happens in the majority of cases where we're trying to regain length. Or you can do a pure closing wedge, which is inherently the most stable, but gives us the least length restoration. Now, the horizontal plane correction in these situations would come after a transverse osteotomy. So if you had to do it, if you were internally rotating a leg, you would do a transverse osteotomy first, then you would internally rotate the distal segment, and then do the closing wedge with obvious controls for rotation while you're doing that. And then you'd have a final construct like this. And then you'd find out which of your blades would fit the best. Where is it going to be the best position of the blade in the head? And once you've decided on that kind of blade, in this case, it's 120. And then we have a final construct with a blade in place. And in most cases, you're better off now taking the drawing on the right and superimposing the proximal femur on your deformity drawing. So this will give you your seating chisel path. You can, in situations in which you have an easy correction, as we've set up here, which was a 30-degree frontal plane correction, then with a 120-degree blade plate, you will have your blade plate seating chisel will go in perpendicular to the long axis of the femur, but it's always best to check this position on your original drawing. And then at this point now, we're going to go back and set up the surgical plan. And so there'll be an orthogonal reference relative to the long axis, a reference at the tip of the trochanter, a measurement to the base of the seating chisel insertion, and then a transverse osteotomy plane and a reference for your closing wedge, no matter where you finally decide to put it. This will give you a correction like this based on the previous plan. And it should be able to be overlaid at the end with this sort of result, okay? Critical components of any kind of femoral plating are the ability to maintain compression across the osteotomy site. Roger's going to go over this more in detail, but you have to understand this concept, and it's critical to success in this situation. You can also correct the axis. It's rare. This is the patient who had a stroke, is nominally ambulatory. This is where he came in at 3 weeks. It's basilar neck. We don't know how long he is, but we can, in this case, just correct to CCD axis with a arbitrary closing wedge that will get him back to a normal CCD angle and with a little more fixation given his underlying osteoporosis. So in summary, what we will do generally is plan to the normal side based on equal rotation AP views of the respective hips. We'll select a corrective osteotomy type, and that can be usually a closing wedge of either complete or incomplete, usually not completely opening. That should compensate for shortening, and we can manage offset with subtle changes in shaft translation. And the goal is minimal distortion of the original anatomic context, so that I would want to ever, in a situation like this, to ever exceed CCD angle of 145. There are more recent papers that document that this is still successful with a relatively low failure rate. And so once you're done with those, and you assemble the correction and fit the implants, and then transfer that construct back to the original deformity, and then that set of drawings or set of images goes to the OR and goes up before the case starts, so that everybody in the operating room understands the sequence that you're going to follow. So with that, thank you very much.
Thanks, Keith. That was excellent. Just remember that we're happy to answer questions kind of while the presentations are going on. Some of us will be monitoring that. But that's a great platform to kind of show us how to plan for what Roger's going to show us how to execute. And so one of the benefits of doing this via Zoom or webinar format is that this video of the webinar will be available on the AO Trauma North America YouTube channel, but it will also be available to you who have signed up. You'll get a link to the Zoom recording that'll be live for 2 weeks. So just remember that. I know that's a lot of information to take in, and I learned something from Keith every time he gives a presentation about planning these osteotomies. So really appreciate that. And so we'll move on to Roger going through the actual osteotomy performance.
Great, thanks, Brett. So while I'm bringing up this share screen, I just want to mention a couple things. The first is that it's really hard to spend too much time thinking about these cases beforehand. The more you think about them, and honestly, the more you draw them out and spend time looking at the bones, the more you're going to learn over a long period of time. And so that to me has been a real valuable thing. The other thing is that if there's ever a time for you to be obsessive compulsive or precise about your technique, this is it. So spend a lot of time thinking about it beforehand, spend a lot of time in the operating room being extremely precise as you go through the operation. Restore the anatomy and then restore the mechanics as well. If you do those things, you'll succeed, I think. So the question then is how do you take that preoperative plan that you've created and then execute that in the operating room? And that, what you really want to do is to be able to go in the operating room, remove your wedge, put your blade plate in, get this compression, this offset compression so that you have good stability at the osteotomy site, and have it look like you had planned before the operation. So, but there's probably, 50 steps in between here, easily 50 steps that you need to think about. And probably the best thing you can do, especially early on in your practice, is to create a surgical tactic, and the earlier you are in your practice, the more details you should put into the surgical tactic. This is a step-by-step list of instructions that you are creating for yourself. This is going to guide you through the operation. So the detail is extremely important, even where you're going to place retractors, especially early on in your career. You want to think about every single step. If you have them listed out, if you ever get kind of lost in the operation, you can refer back, as Keith mentioned, to that plan that you have hanging there on the wall. Everybody knows where you're headed, and you can use it all the way through. In the end, what you're looking at, the only reference you have in the operating room is just a lateral cortex of the femur. You're not going to dissect all the way around the femur. You're not going to dissect all the way around the neck of the femur. So the lateral cortex is your point of reference. So everything you do on this plan, which is, looks really clear here when you're looking at the plan, but somehow you have to translate that onto the lateral cortex of the femur and make it workable. So this is your plan with all your pins on it. You have a 90-degree pin, a 70-degree pin, a 25-degree pin. And like he said, it will vary every time based on how you want to make that osteotomy look, right? So every patient's going to be extremely different. There is no one recipe for this. And that's why thinking about the operation a lot, doing a few different configurations of it before your surgery is really important to see which drawing, which plan you like the best. In the end, though, it's pretty simple, right? You only need really 3 pins to guide yourself. You need 3 pins in that lateral cortex. You need 2 pins that are going to guide your saw cuts. And you can either put those pins right where the saw cuts are going to be, or else a little bit distal to that, which is generally my preference. I find that the pins get in the way of my saw blade a little bit. So you'll need those 2 pins, and then you need 1 pin that's going to guide where your blade plate seating chisel goes. And that's really what you have to do, but you have to do a lot of things in order to get those pins in the right place and to be precise. So you need 1 pin here in the red lines. It's going to guide one of your cuts. And you need another pin that's in the lateral cortex femur. It's going to guide your second cut. And then you're going to need this pin, which is generally real high in the trochanter, still in the femoral head, that's going to guide the placement of your blade plate seating chisel. Now, there's a much longer description of this whole process that we have on the YouTube channel that we did for the osteotomy course. So you can refer to that as well, because it goes into it a little bit more detail. But this is what your plan would look like in the end. Now, as I said, in order to get those 3 pins in, you need some sort of reference, and this would be the reference pin. And normally this pin is the first thing that you would do once you go to start place your pins in the femur. You're going to put the 90-degree guide on the lateral cortex of the femur. You're going to look at it radiographically. You're going to make sure it lines up pretty well. And one of the things I would tell you is that pay attention to where you put this 90-degree angled guide or any of your guides on the lateral cortex of the femur. Because as you know, the femur has been through some trauma. Sometimes it's slightly irregular in shape. You want to make certain that you're using the right area of the cortex on the side of the femur that you planned off of beforehand, right? So wherever you planned off of, wherever you made those measurements, that's where you want to use. And you have to make certain that that pin goes in directly at 90 degrees, because everything subsequent to this, all the other pins are going to be based on this 90-degree pin. The other thing I strongly recommend when you have a drawing is that you do these measurements, that you measure how far from the tip of the trochanter down you're going to put your blade plate seating chisel. And you can make a little mark on the actual femur intraoperatively, either a little bit of bovie mark or something, or an osteotome mark, small osteotome mark. And also make a measure of where you want where the osteotomy is going to be, what portion of the lateral cortex of the femur the osteotomy is going to be at, and make a little mark there as well. And these things will help you decide where to put your pins when you go to place them. So that reference pin, or the reference for the placement of all the pins, and therefore all the cuts, and also the blade plate, is the lateral cortex of the femur. So think about where you're going to place that guide when you do it. The other thing I strongly recommend to you when you do this is that you use this 2mm drill bit. So this is a little bit stiffer, a little bit less flexible than, say, a 2mm guide pin would be. So you pre-drill both cortices with this 2mm, and then you take the 2mm pin and just place it in by hand or give it a slight tap with a mallet, and then make certain that it lines up at the end. And then that reference pin is where you use what you use to make the rest of the measurements. Now, I do sometimes use a sterile goniometer intraoperatively, which I think is extremely valuable and very helpful, especially for the guide pin that guides the blade plate seating chisel. But if you look in the sets, these blade plate sets, there is every iteration of an angle in that set. So it starts at 20 degrees, and I think it goes all the way up to 110 degrees at 10-degree increments. There's an angle in there for everything. If there isn't, you can always bisect it. So what you're seeing here is using this angle here and bisecting it through the middle of that circle, and that will give you half of whatever that angle is that's sitting against the cortex of the femur. So again, you need the bottom pin to guide one cut, second pin to guide the second cut. And usually what I'll do is the second pin that I'm putting in for my second cut, I'll reference that off of the first pin that I put in, not the 90-degree pin, but the first pin that I put in for guiding my lower cut. And that is, in case I've made an error at all in that placement of the first pin, I still have exactly the size wedge that I want to remove, right? You're not summating error as you go along in that case. And then again, a sterile goniometer intraoperatively is extremely valuable, especially because you have to look way at the top of the trochanter to put this final pin in to guide your blade plate seating chisel. And that's a long way to use your eye to calculate where that pin goes in based on one of those small triangles. So I do think a sterile goniometer is very helpful. Intraoperatively, you're not going to make a drawing like this, right? You're not going to draw over the anterior cortex, but you can draw over the lateral cortex that you're looking at and give yourself an idea of where your wedge is going to be, how big that wedge is going to be, like how far down from the trochanter is going to be where your blade plate seating chisel goes. You can make that mark, and then how large the lateral cortex wedge is. And you can make a little mark there as well with a small sharp chisel. I do sometimes use this drill hole technique with the 4-5 drill bit, but I would say most of the time, instead of doing that and using the router, which I think is helpful and extremely hard bone, but most of the time I'm just using a couple of small, very sharp, thin stiletto type osteotomes in order to make this window. And you certainly want to make it large enough, especially in hard bone, so that you don't explode or break apart the proximal femur, because that can happen to you. Give yourself plenty of room there. The next thing you're going to do is start to put in this blade plate seating chisel, and you're going to tap this in increments. You don't want to just keep pounding it in because it will get stuck on you, and you will have a really difficult time trying to extricate it. And I can tell you this because I have done it, and it can be very hard. So work it in a little bit. You're trying to create a track that has memory. So you tap it in a little bit, back it up with the tuning fork, tap it back in a little bit, pull it back out with the tuning fork. Also look at it and think about the sagittal plane. So that's what this guide is for. It slides right over the blade plate seating chisel, and it tells you, what your correction is in the sagittal plane. So make sure you use that. Put it on, take it off, put it on, take it off a number of times. Recheck yourself. Be very precise with this. These numbers typically on most of the blade plate seating chisels are illegible, but you should know how deep that you're going to place this seating chisel before you start. It should be part of your preoperative plan. And you can look and do this. Now, back in the day, people weren't using fluoro to do this, and they would just tap in and base their entire osteotomy on these numbers. But we have the ability to sort of confirm this with fluoro. And you should, at the same time, make certain that that seating chisel is going into the right part of the femoral head. Remember to back the blade plate seating chisel out about a centimeter, at least a centimeter, before you start making your cuts. If you make your osteotomy cuts with that blade plate seating chisel all the way into the femoral head, there's nothing really that's stabilizing that proximal segment, and you're just rotating around the center of rotation in the middle of the femoral head. And every time you try to back out that seating chisel, it just spins the fragment. You just don't have enough resistance in order make it happen. And sometimes it can be extremely frustrating trying to back that out. So back it out about at least a centimeter. You want to take it out far enough so that it's not wobbly in the chisel track, and that you can extract it basically just by hand. You can pull it out by hand or a small tap onto it using the tuning fork. Once you've done that, then you can start to safely make your cuts. So you want to make the shorter limb cut, first. Or if you make it second, you don't want to complete the long cut. So let's say you want to start with a long cut. You'd only take it up about 3/4 of the way, and then you'd make the short limb of the cut. And that's because things become relatively unstable once you've dissociated the proximal segment from the distal segment. So it's helpful if you have completed the shortcut before you make that long cut. And that would typically be what I would do. Sometimes you have to externally rotate the femur because the length of these small oscillating saws may not be quite long enough, especially if somebody has remodeled and formed some bone on the medial aspect. So you may have to actually rotate a little bit in order to complete that cut. Use the saw blades that are extremely thin. The ones that I use are 0.6 millimeters thick. And this one that you see here has a little measuring guide on it. So it gives you an idea of depth, and it's a little bit fan shaped. But a smaller, thinner blade generates a lot less heat, takes away a lot less bone, and actually is a much more precise instrument. So that I would strongly recommend. Once you have those cuts, you can pull out your distal pins. You don't really need them anymore. And you can leave that proximal pin as a guide for placing the blade plate itself. It's handy once you pull out that blade plate seating chisel to have something still to guide you, because that proximal segment is now mobile and it's moving around a little bit. And then you're going to exchange the seating chisel for the appropriate blade plate that you should have already lined up based on your preoperative plans. In general, the optimal plate for femoral neck non-unions or Powell osteotomies is most commonly the 120-degree plate. And that's because, as Keith said, you're generally shooting about a 25-degree and sort of maximally a 30-degree correction. For me, it's extremely rare to be doing anything more than a 30 degrees. So most of the time I'm landing on a 120-degree blade plate. As Keith mentioned, this is an extremely important point. And if you don't know how to do offset correction, you have to learn how to do it before you do this operation. Because you have an oblique slope here. And if you have a 120-degree blade plate sitting up into the femoral neck here, and you put the articulating tensioning device on the end of the plate here and you pull on it, theoretically, you could pull this blade out of the bone. And it just is not the way to achieve compression here across the osteotomy site. This technique of offset compression is. So what you want to do is you can create this little area here of offset and use small block of bone, a small instrument, something that will give you this offset. And then what you're going to do is the distal end of the plate you see is against the bone already, and you're going to place a distal screw in. Now, most of the time it's indicated. A lot of people put in just a unicortical screw. Some people will put in a bicortical screw, but a unicortical screw will work. And then you'll be able to remove the thing that is creating that gap between the plate and the bone. You're going to place a screw in there. And what this screw does is, as it closes down that gap along the lateral cortex, it's going to drive the proximal segment medially. And because you have an inclined slope there, you're going to end up with compression across that osteotomy site. This is extremely important. You have to have this. If you don't do it, I can guarantee you your osteotomies are going to fail, or a certain portion of them are going to fail. And this is an extremely important part of the operation that you have to do. So in the end, this is hopefully what you'll look at. I can tell you, if you take time doing this, you spend a lot of time with the preoperative plan, you're very careful with your intraoperative technique, you're extremely precise, then in general, it'll be extremely successful and rewarding operation for you. If you don't do those things, if you're not really precise, you're going to have a bad experience with this, and you'll probably never do it again for people. And it's an important part of your armamentarium as a trauma surgeon to know how to do this well. And that's it. I'll hand it back over to you, Brad.
Thanks, Roger. So the last lecture that we're going to have is from Joel Williams, who's going to talk about complications and pitfalls. That was a great walk through how to do the osteotomy, and several critical points were mentioned. So again, the video will be available on the YouTube channel, as well as you'll receive an individual link. So we're happy that we'll be answering questions after this last one live, but you can also get things answered in the Q&A section as well. I'll turn it over to you, Joel. Just remember to
Sorry about that. I had an issue sharing it. One sec. All right, is it working?
yes.
Okay. So I think this is why Brett invited me. You know, I'm sure Brett doesn't have any complications. He said, bring on the new guy, show us how to make some mistakes so we can all learn. No, in all seriousness, what Roger just finished with is entirely true. And if you spend the appropriate time examining the patient, coming up with a plan, and take your time and be precise in the OR, your odds of having success and minimizing complications are as low as possible, but even still, I think some amount of complication or error is unavoidable. There's numerous complications, but I only have 5 minutes, so I picked 4 to sort of get through, 2 of which I have had personally, the top 2, and then the other 2 I'm going to share some other cases from the panelists. So the first is lateral cortex insufficiency. So this is not a blade plate that was inserted for a non-union. This is a 20-year-old patient that I treated for a congenital deformity of her femur. And I think it really important, despite it not being a non-union case, that demonstrates the importance of the bone between the blade plate and the osteotomy site. So this is her immediate post-op x-ray. And overall, I thought the case went well. You can see the summation wire at the top and the blade plates going in at the image on the left. And you can see on the image on the right, the blade is drifting a little bit cranially. So I put on this vapor clamp to control the proximal segment to direct the blade a little bit further caudal, where I sort of drawn my preoperative plan. You saw the post-op x-ray. She came back to clinic for her initial post-op visit at 2 weeks like this. So I think the safe distance between the blade insertion site and the osteotomy location is 15 millimeters. I think if you have very young, healthy bone, you might be able to get away with less or a smaller distance. But if you're too close, or the bone integrity between the blade location and the osteotomy is insufficient, this can happen. So this was this procedure, to revise it, with a proximal femoral locking plate, was done end of January, and she's doing well so far, but she's still healing at this point. Second one can happen with any implant, really, especially the blade plate, which has to be incredibly precisely placed. This is a subtroch non-union that I treated last year. Here's her post-op x-ray. AP was happy with, and I kind of freaked out when I saw this lateral image. My first step was to immediately replay the fluoros, and I think these images make it look safe. And, you know, I think it's important at the end of a case like this to get multiple images to be sure that you're confident with the with safe location of all the implants. So this image all the way to the right on this screen is a bit concerning. I got a CT scan, and unfortunately the axial is not playing. I think the sagittal shows though the point, and I'll stop it right about here. So it's entirely within the neck. And it's, I think if I had dissected down into that portion of the femur, you would see a sort of a dent where the blade was pushing from inside out. And discussed the situation with the patient. And both of us felt it'd be best to leave it. Showed it to a couple of colleagues and mentors as well, because I hadn't been in a situation like this, at least that I was aware of. She's now healed and has no, her non-union's healed, but also, you know, every time I see her, I do a detailed examination of her hip, and she has no mechanical symptoms. Pitfall 3 is inadequate compression. So just as Roger said a number of times, and Keith said a number of times, you have to find a way to compress. With any blade plate angle above 95, I think mismatched compression is a better option than the articulated tensioning device. This is a patient that's 78 years old, or she was 78 years old when she came into clinic. She was referred for this proximal femoral deformity, non-union, I think about a year or several months after her accident. She's elderly, she has osteoporosis, she's a former smoker, as it says right there, 1 year after hip fracture. She was revised with a valgus intertrochanteric osteotomy, and allograft was used to fill in the gap. Here she is 4 months post-op, and if we compare it to her immediate post-op, so this is immediate post-op, this is 4 months post-op, you can see that she's lost some of her correction, and then at 4.5 months, she ultimately failed. So this was the second operation. She was revised with a higher angle blade plate. Local autograft from her femur was used in addition to BMP. There was complete takedown of the fibrous non-union, and this was tensioned with the articulated tensioning device to 150 kilopascals. And here's your final x-ray, 3.5 months post-op. And lastly, as you've heard a couple of times, picking your angle of correction in the modern era, I think, is seldom above 30 degrees. So this is a patient that, if you follow the strict initial Powell's recommendations about minimizing shear, should get quite a large correction. So that kind of what was done is a pretty high angle correction. I think it was very successful in many ways. It's really nice that the neck non-union and the osteotomy sites healed, but her hip joint became symptomatic, or remained symptomatic, after the osteotomy and the non-union site healed. She ended up getting revised to with a varus producing osteotomy to restore normal hip biomechanics. So, you know, we could fill an entire hour with potential complications, pitfalls. These are just 4, I think, that are hopefully avoidable with proper planning and careful execution. But, you know, I think it's fair to say if you do any number of these types of procedures, at some point you're going to have problems, and that's okay as long as you're you know, honest about addressing them and share it with the patient to come up with the best plan possible.
Thanks, Joel. All right, so now we'll take some questions. We don't see any in the Q&A function right now. So if you guys can think of anything, just go ahead and type it in. I had a question for Roger. You mentioned a little bit about kind of thinking about how to get through the proximal femur as far as whether you use the drill bits and the chamfer cut, or do you, but how do you address if you have previous implants like a sliding hip screw or a nail? Do you have any tricks to try to getting through that sometimes sclerotic bone?
Yeah, I mean, I have a couple thoughts when I think about that. The first is that you have this track that usually has some windshield wipering through it, and you have to think about which of your implants you're going to use, right? So some of the angled blades, like the 120 or the 130, might not be right because it'll put the lateral part of that blade plate too close to where the deficit or the defect would be, and you'll end up with that cutout situation like Joel had shown. So typically you want at least 15 millimeters. So sometimes you can use a lower angle blade and then have the chisel angled down into the head, so that gives you a little more clearance. And then the issue that I think you were probably driving at, and that is, let's say you have a track with, that have previous implants. Screws generally aren't that big of an issue, but if you have something that has a, cephalomyxillary device that has a large screw that goes up into the head, one, you're going to run into a track. You're going to have to cut obliquely across a track that may have cortication along it, right? So that's going to want to deflect the blade plate seating chisel, and you have to watch that very carefully, because if it does, you can go in there with a drill and make a couple penetrations in that cortex inside the femoral neck in order to allow that chisel to get across it. That's another thing. And then always remember that you may have sort of a cavitary defect within the femoral head that is sitting above your blade, and that in general, I'd recommend trying to fill that usually with maybe a piece of fibula or something that's been, really carpentered to fit exactly in there, not get in the way of your blade, so that your blade doesn't cut out into that defect. And I just know that because I've had it happen to me before. And I've done a really good job where I've put pieces of fibula up in there, it's out of my way, and that seems to be a reasonable solution for that particular problem. So that's probably a long-winded answer to your question.
No, that's exactly what I was hoping you'd get at, because I think the fibular struts are very helpful for kind of augmenting the path of the blade plate chisel. Keith, do you have, or Joel, do you have any other tricks as far as getting through either previous hardware paths, or I know Joel showed in his revision case kind of the way he managed it with more compression and allograft and BMP, but do either of you have any other tricks as far as dealing with previous implant tracks?
Yeah, a couple times I've used a really long pencil Midas Rex burr to go across the track. I think Roger's comment about being the bigger the angulatory deviation between your anticipated blade plate and the old track, the better. The worst thing you can be is somewhat parallel, because you'll never be able to really regain purchase again. So I think you can take advantage of the sclerosis of the old implant path, but you have to be probably more than 10 to 15 degrees off that axis in order to get safely across. And I would almost always use the cannulated chisel in those situations, because I think that if you're really careful with it, it's a useful adjunct.
Joel, and that's great. That's a great point. I think that's very helpful. Joel, any other comments?
No, I think I love the fibula idea, Roger. I'm going to try that. I've used allograft to fill a large defect before from a cephalomyxillary nail and packed it in sort of with the triple sleeve from the X-Fix set. But I agree with intersecting at the largest angle possible to avoid the sclerotic bone deflecting the blade. And Keith, you just touched on the cannulated seating chisel. Would you say, this is a question for everybody, would you say you use the cannulated chisel more often than the non-cannulated chisel, or vice versa?
Yeah, there's no good way to answer that without incriminating myself. But since I'm responsible for the cannulated chisel, I'll admit it. Yeah, I use it most of the time. Yeah. But it's just like anything else that's cannulated. It's not foolproof, as you know, because fools are so ingenious. So you have to be extremely careful with it. You can drive it across the joint, you can break it. All the things that you heard from anterior cruciate ligament literature and any other place, you can use anything that's cannulated pertain there as well. So it's a modest improvement.
I personally use it when I'm having a hard time getting across a prior implant path, but I would say that's maybe 20% of the time. So I use the non-cannulated one mostly.
Yeah, I'm the same. I almost never use a cannulated one.
There were a couple questions. So one question that's a very good one is, what do you do with a femoral neck non-union that's mobile? So how do you stay? Keith responded a little bit in the chat, but I thought I'd get everybody's thoughts. Like, how do you guys prevent it from moving if it's a truly mobile non-union before you do your osteotomy?
Yeah, I can take a stab at this. I've seen it a couple of times. And so I've had these cases where I come with these beautiful drawings and I plaster them all over the wall. And then I pull the implants out that were in there and I pull on the leg a little bit and the head just kind of moves and rotates up a little bit. And every single one of those drawings is now completely useless, right? So, so I usually don't, I try to actually use that to my benefit, right? So if it's mobile, I'll actually take, without being too aggressive, whatever it will give me out of that and recalculate what my angles have to be and where the blade has to be. But normally this means that I gotta kind of have to scrub out, take some decent images at the time with the traction on it to see where it is and to refigure what that's gonna be. I don't do it, like I remember when I was a resident, people would, if you had a slipped epiphysis, like you weren't allowed to move the slip, right? You had to just pin it in place. But I don't treat this like that at all. I take what it'll give me, and then I'll fix it in a new position and recalculate.
That last case, they didn't show the intra-op or post-op x-rays from the last slide in the first talk with the MRI, but that was completely mobile non-union. So in that situation, I did two different exposures. I did a Hoyter exposure to reduce the femoral neck with a Jungbluth. I think that's the only time that I've done that. And I think it's way overkill in the vast majority of situations, unless it's completely mobile and you can't control it, or if it's a long-standing non-union.
Keith, do you want to just verbalize what you'd mentioned in the chat, just in case people didn't see it?
Yeah, I think you have to be careful about mobility. It really depends, if what you're getting is an improvement in the frontal plane and you're gentle with it, it's probably fine to take advantage. It's only occurred to me twice, and in both cases, I just went back to the standard training, which is expand your exposure. I did not use a Hooter. I just expanded my exposure into an anterior arthrotomy. So you're looking at it as you're actually assessing motion. I'm worried about trying to correct version without really knowing what's going on with the circulation. So if the goal here is to preserve circulation, although I've not seen cases of secondary aseptic necrosis, there's certainly been reported with this operation. And so I think general frontal plane corrections are fine. I probably would not try to improve the horizontal plane, even if I thought it was possible.
There is another question about preoperative planning. Keith, I'll have you start. Is there tips or intraoperative techniques to verify the position of the blade in the neck as far as in the sagittal plane? Do you have any tricks, since we're like when you're doing your tracing paper, or any tricks you do intraoperatively?
Well, I think you should plan the set. I mean, you should plan for the rare case where you have a sagittal plane correction, because you can certainly do that with a blade. Most of these, again, the sagittal plane can be a component. So there are multiple additional planes of deformity with femoral necks. The one we showed showed a rotational problem, and it was rotational along the neck axis. But I think in general, the imaging, when I first started doing these, I did them supposedly. And that's because that's the way I was taught in burn. And it was always, you're sitting, you have a direct neck exposure, and we didn't use the fluoro at all. In fact, the fluoroscopy unit was in the basement. And so then I went to lateral position, and all of a sudden, things dramatically improved. So an oblique profile view of the femoral neck for putting in a seating chisel is vastly superior to trying to hold some type of frog lateral in a supine position. So if you haven't done lateral proximal femoral osteotomies, I think it's worthwhile doing one, because I think the imaging in many ways is easier, and it certainly, I think, helps with exposure in bigger people because the soft tissues fall away from you. So you can do it either way, but I think the accuracy of the blade plate on the lateral view is much greater in the sideline position.
Yeah, I totally agree. Since I heard you talk about doing lateral position, I totally switched to that, and it's made my life a lot easier for sure. Why don't we go ahead? There aren't any other questions. We'll go ahead and go to the case. I'll have you all kind of chime in and give your thoughts. So this is that patient that we saw at the beginning. So again, 36-year-old firefighter, 20-foot fall at work 9 months ago. On clinical exam, he had a centimeter shorter on the right while standing, but putting a ½ inch block under the injured side, or the right side, leveled out his crest heights. He had mostly pain posteriorly with an opposite leg, straight leg raise. So raising his left leg for a straight leg raise caused posterior buttock pain on the right. Couldn't do a fader or Faber because he had too much groin pain. He had a positive C sign. He had 4 out of 5 hip flexion, abduction, and adduction, all of which caused groin pain. No history of infection. His other injuries that were listed, healed. He was getting like his distal radius plate out at some point by somebody else. But he was basically referred to me after the person that fixed him. The work comp folks sent him to an arthroplasty surgeon who said he should get a total hip. The trauma surgeon that fixed him asked if he could come see me. And then, so he has the impression that, total hip's the option, but doesn't really want a total hip at 36. And so these are I just get a young adult hip series for these hip pain patients that are less than 50. So this is false profile and cross table lateral views. And if I didn't say it, he didn't have any history of infection. Here's somewhat a frog leg or done view. He has some, he does have an excessive alpha angle on both sides, but didn't have any previous hip pain prior to this injury. So I got his Powell's angle at about 85 degrees. His CCD angle, and this is with him standing. I could have done the supine one, but this is with him standing. I got the right side 123, left side approximately 134. And then here's CT scan. And we'll do the axials and then the reconstructions here in a second. Here's the coronal plane, sagittal. So he shortened up a little bit and was in varus. And this is his 3D reconstruction. You can see the at the lateral cortex, his screws had protruded some. And then here's his rotational assessment. Our CT techs or radiologists can't give me a gun sight view, so I get to measure them both. And so I didn't really feel like he had a lot of retroversion through his neck, but I did feel like from his, I measured a couple different levels of the neck, but I thought he had 2.4 degrees or 2 degrees of retrotorsion. And on the left side, he had 6 degrees of antitorsion. And so the problem list, 36-year-old, prior to this, active firefighter, has a painful transcervical femoral neck nonunion, Powell's angle of 85 degrees. He has about 10 to 11 to 15 degrees difference in his CCD angle, some rotational difference from his left side, and approximately a 2 centimeter leg length discrepancy. And then I do metabolic workup for all the non-unions, and it was normal for him. And so half-inch lift on the right side, leveled him, not on this x-ray. I don't have the extremity alignment series. So with those things in mind, what are your guys' thoughts?
I'm not sure where his pain's coming from, frankly. How far out is he?
9 months.
Yeah, I'm not sure that he's not partially united and that his pain is not from, I mean, if you look at his contralateral side, he's got a wide neck, he's got no offset, he's got borderline coverage. So this is not, if this were a match set, he was sort of set up, and he has essentially what is he has an acquired slip, basically.
Yeah.
It's not a big slip, but, and he's got that metaphyseal, he's got the equivalent of that metaphyseal ridge, which is abutting his anterior rim when he flexes. And so given how non-specific most of our findings are, I'm still not sure that this pain is from non-union rather than from deformity. Not that it makes a whole lot of difference, except that if you think it's just a offset problem, then you could introduce other options. Not that I would, but I mean, I'm sure there are a lot of people in this country that would end up with an arthroscope in their hip with this problem.
He definitely, any kind of even a log roll was positive for him, which most of the time isn't that positive. At this time, like any hip range of motion really bugged him. It didn't have to be where I thought he had enough. Like, I think I got him to about 70 degrees of flexion before he really wanted me to stop.
And weight bearing was a trigger for him or increased his pain?
I'll be honest, I don't remember. He just said his pain never got better. And I think he started weight bearing at 3 months, if I'm remembering correctly. Roger?
Yeah, it's just, there's a couple of thoughts that I had. One is it seems like the measured 2 centimeter leg length discrepancy is awful large based on the deformity that I'm seeing here. So I'm not exactly certain how that was measured. My eye was looking at the lesser trochanters and I was thinking, there was a centimeter that we were shooting for there.
Yeah, he said the half-inch made him feel normal. His iliac crest feel normal. So as a clinical,
I personally would not worry too much about sort of the retrotorsion portion of this. Like Keith, I probably wouldn't spend too much time thinking about that. On the CT scan, you could see that, the bony prominence over the anterior part of the neck, and I'm not thinking that I'm going to debride that in this particular operation. Certainly a total hip replacement is not a good answer in a 36-year-old guy. And I would probably do, an osteotomy. My goal, I think, here would be to try to get the tip of the trochanter in the relative right position compared to the center of the femoral head. So, where the tip of the trochanter is either at the point of the center of the femoral head, or I can't right now see the other side very well, but just because but I would probably try to go a little bit lower. The other side looks like it's a little bit higher, right? Tip of the trochanter is a little bit higher than the center of the femoral head. I would probably shoot center femoral head to the tip of trochanter, or maybe just a little bit lower, slight overcorrection because this is going to be a little short. And I think you could benefit from that.
So what you said that you wouldn't address his rotation. I would put this out there. What about, since Keith brought up, arthroscopic osteoplasty or something like that, what do you think about increasing his antitorsion so he wouldn't engage that?
I like that strategy. I think I'd have to draw it out, but probably transverse osteotomy, like Keith showed in his planning, just above the lesser, and then I'd have to draw a 10, probably a 20-degree correction. But I think in addition to that, probably a horizontal plane. And you said the discrepancy is around 10 degrees between left to right?
10 to 15, depending on how we measure it, but it's 11. I mean, I get 11, so 10's fine.
No, the horizontal plane discrepancy. 2.4 in the effect.
Yeah, 2.4 of retrotorsion versus 6 of antitorsion on the other side.
So roughly 10. I think getting into increments smaller than 5 degrees with a sterile goniometer is nice conceptually, but it's, measure with a micrometer, cut with an axe type concept.
So what's his rotation and extension?
With him, like supine, you mean?
Yeah, supine.
Can I go back a couple slides? I had him, I basically wasn't able to do a whole lot of motion because he was having so much pain on that side. So
Yeah.
like any kind of like if you had him try to get him to 90 degrees or even supine, like he really wouldn't give me a good rotational exam because at that time it was hurting too much.
Yeah, I think that presentation is not classic femoral neck non-union pain. They're not that uncomfortable. You don't see much evidence of implant loosening. You see small areas of bridging on his CT. And so to me, his pain is impingement related. And so maybe he does have a partial non-union, but I think that the real issue here is impingement. And you can address all of them at the same time. The problem is that with that metaphyseal prominence, in order to get that out, so if you look at his acetabular version, I mean, he has a relatively norm. He has a positive posterior wall sign, so he's either got borderline dysplasia or I can't really tell for sure what's going on, but he's basically going to have problems with impingement unless you overcorrect in the horizontal plane on the femoral side. So for me, what I would do is a modest abduction, probably, as Roger said, enough to get him down to a trochanteric tip at the hip center. You can see on the other side, he has mild varus in terms of that definition of varus. And then I would instantly rotate him by at least 15 degrees, probably 20. I don't think that 20 degrees of rotation would be a problem. And that'll make it happy. You probably still won't give him adequate clearance and flexion. But that'll leave him with, mid-teens total antitorsion. Okay, version and torsion combined. But it'll certainly give him a lot more freedom of motion. And at the same time, then I don't see any reason to do anything directly at the neck level. You can certainly expand it. You can address that metaphyseal ridge with an arthrotomy, either from a separate hooter or just an anterior capsulotomy, like we used to do it in the old days.
Okay.
Keith, say it again. What are you thinking of horizontal plane, the degree of correction?
Yeah, I think I would rotate him 20 degrees.
20.
Yeah.
All right. So this is the free online planning software that Raul Vadia, who's one of the AO faculty members, helped design. It's called Detroit Bone Setter, and you can go to that website and they'll get you a free account. And so this is basically showing like the overlay technique. I just flipped it, and instead of isolating it to a hip, I wanted to show both sides. So basically the purple is the right side flip to match the uninjured side. And then the crosshair mark is basically like where the rotation point of the osteotomy could be. So if you have it totally on the medial side exit point versus a third of the way towards the lateral cortex to try to give a more leg length change. And so this is basically what the on the left side, or sorry, my left screen left is doing that same thing. And then on the right side is kind of the drawings that I made on the intraoperative imaging that I could see where the blade plate's going to go in. And then basically using that exit point to get around a 30, I tried for a 30-degree correction to try to get the leg length change where I thought I would get it close to the other side. And so this is rotating it. And so you can see the rotation of 30 degrees there at the bottom right. And so that's what it looked like. Using the intersection point, not at the medial cortex, but just slightly more lateral, like I showed. And then this is in the lateral position. And I have had 2 times where I've had a neck non-union move on me when I was trying to do a blade plate. And so I actually have gone, if there's room, placing screws across the non-union first, partially threaded screws. And so this is getting the rotational assessment with the wires, but also putting a screw proximally. I thought there was room. So there's the cannulated screw with the washer to compress and avoid displacement with a blade plate. And Roger's right, screws aren't as big of a deal as like a sliding hip screw or previous nail pathway, but it's freaked me out enough to where I pretty much do it consistently. And then this is the blade wire, and this is not using the cannulated, or this is using the cannulated guide, sorry. And so you want to use the side plate reference that goes onto the blade plate chisel to see where the plate's going to end up on the femur on the lateral view, as well as clinically to avoid any sagittal plane correction. And so this is using this is a different case, but using the blade plate chisel as one reference, and then for the distal segment, putting in the amount of correction that you want to get to where when you're done rotating the distal segment, you'll line up with the blade plate chisel. And you need to make sure that you get it far enough away to allow for whether you're doing an ATD, if it's a 90 or 95 degree plate, if you're doing a fracture or whatever, if you're going to use an ATD, because it'll take up more space. And then this is executing the transverse, and then I internally rotated this distal segment 20 degrees to give him basically 15 degrees, between 15 and 20 degrees of antitorsion, and then made the mismatch or offset compression screw distally unicortically, and then put this first screw in, and I aimed it a little too proximal because it bent as it was lateralizing the femur. So I redid that and then compressed it. As you can see, I thought the lateral cortex lined up well. And then this is the rotational assessment. So a true lateral of the knee, and then an axial lateral of the proximal femur. And there's 10 degrees difference, or 10 degrees of antitorsion, 15 degrees and 20 degrees. And so I thought I was around 15 degrees for the antitorsion with the correction. Here he's post-op, and you could say, well, maybe I overcorrected him, but I thought it was compressed well. I don't like the post-op images as far as telling that, because their legs are always positioned weird. But here he's at 13 months. He's actually not having any groin pain. He does have back pain, and actually was going to get some epidural steroid injections from chronic low back pain issues. But his gait normalized. He felt like his leg lengths were equal. He didn't have any signs of avascular necrosis or impingement. And I should have got his most recent physical exam as far as his motion, but he had a negative Fader and Faber. And so in summary, we're running out of time. So the take homes: common deformities and femoral neck non-unions are obviously shortening, varus, and you can have some apex anterior changes or retroversion. You want to, as Keith showed elegantly in his planning talk, you want to recreate the proximal femoral anatomy and improve the fracture healing environment at the same time. And then planning the procedure is as important as doing it. So this is, again, the AO Trauma North America YouTube channel is where you can see this will be up there probably within the next few days, for sure by next week. But there's also the entire online osteotomy course available, different surgical exposures, the pelvis and acetabular course. There's lots of great content there. So just remember, 36-year-old firefighter, should he really get a total hip? I think most of us would say no. And I do total hips. They're fun to do and people do well from them. But in a 36-year-old active person, he ended up being out of pain at 13 months. So upcoming webinars, April 21st is distal femur fracture, September 15th, scapula and glenoid, October 13th, acetabulum is the radiology of the acetabulum fracture types. November is then bone defects, non-unions, osteomyelitis for trauma surgeons. Thanks for joining us. You should get, I think, some evaluation questions. Is that right, Mark?
No, not for the fellows.
All right, so we're good. Thanks again. Appreciate everybody's attention and look forward to interacting with you in the future.